Hello, everybody. Welcome to another ASG author interview podcast from the Technology Committee. My name is Ryan Law. I'm the current chair of the Technology Committee here at ASGE. The Technology Committee provides reviews of existing, newer, emerging endoscopic technologies that have an impact on the practice of GI endoscopy. Our goal is to produce status evaluation reports using evidence-based methods with a Medline literature search to identify any pertinent clinical studies on the topic, as well as MAUDE database adverse events on a given technology. Both of these sources are supplemented by assessing for related articles featured on PubMed and by scrutinizing pertinent references cited by the identified studies. We aim to include controlled clinical trials, but in many cases, data from randomized trials are lacking, particularly in endoscopy. In such cases, large series, preliminary clinical studies, and expert opinions are used as suitable alternatives. We aim to gather technical data from traditional and web-based publications, proprietary publications, and informal communications with pertinent vendors. These technology status evaluation reports are drafted by one or two members of the ASG Technology Committee and reviewed and edited by the committee at large thereafter. Today, I would like to welcome Erik Rahimi and Guru Trikudanathan from these were the primary authors for an upcoming document that will be in gastrointestinal endoscopy regarding the management of gastric varices. I would like to welcome them to the podcast and appreciate their effort on this document and their time today. Welcome.
All right, thank you.
So, Guru, I'll start with you. Why did you and Erik believe that this particular topic and document was important for the ASG membership and for patients, and something that our technology committee should pursue?
Thank you, Ryan, for this opportunity. So gastric varices are seen in really nearly 20% of total hypertension. Fortunately, gastric variceal bleeding is less common than esophageal variceal bleeding. But when gastric varices bleed, they are associated with higher rates of uncontrolled bleeding, increased blood transfusion requirements, increased prospects for rebleeding, and overall an increased mortality. The landscape of gastric variceal bleeding management has changed and it has evolved with the advent of EUS especially. And we at the technology committee thought it was timely for us to get together, review the current state of literature, and also provide some practical guidelines to the practicing clinicians.
Yeah, I completely agree with you. This is a really high quality document which contains a lot of information, both on technology, but also on technique and on available data supporting the use for management of patients with bleeding gastric varices. As you mentioned, there has been some evolution in this space. So with that, we'll start with Erik. Erik, can you explain a little bit about the data not the data, but the information contained here within this document with regards to endoscopic intervention, and then we'll talk to Guru about the EUS guided interventions.
Yeah, thank you, Ryan. Yeah, I would separate it between the endoscopic portion and the EUS portion, but going back in time, a lot of people used to sometimes use sclerotherapy, band ligation, and now the main method of treatment is with tissue adhesives, either cyanocrylate or thrombin for isolated gastric varices or GOV type 2. I'm going to point out that GOV type 1 is treated like esophageal varices, and so we're more focused on the IGV, the isolated gastric varices, and GOV type 2 for treatment methods with endoscopic methods. As far as fluorescence, you have to use a large volume. These are big vessels. It wasn't ideal. People had complications of pyrexia, ulceration, and just had high rebleeding rates with those types of treatments. When it comes to variceal ligation, obviously for esophageal varices, that's the treatment for that. When it comes to gastric varices, these are large vessels. They're plumpy, they're round. It's hard to grab the tissue with a ligation into the cap. And then also the vessel is deeper in the submucosal, so you're not grabbing that vessel with the ligation. I would say in a dire situation, if there's no other availability for glue, these are temporizing measures that can be used. But someone does, if they do those measures, they do need to go and get something more permanent to affect that either with glue or undergo EUS. So today, the majority of treatment is with cyanoacrylate glue. And these are tissue adhesives that basically polymerize and harden once someone injects it inside the varix. I can
Fantastic.
Yeah.
No, that's fantastic. Typically cyanoacrylate with direct endoscopic intervention tends to be more widely available than the EUS guided approaches, though I think that we're starting to see the EUS guided approaches maybe catch up a little bit. Certainly, the endoscopic intervention with direct injection is a valuable technique and easily performed, something that you can use in combination with Doppler probes through the endoscope as well to assess your kind of how well your intervention has gone in terms of polymerizing within that varix. Switching gears a little bit, Guru, can you speak to the EUS guided approaches?
So sure, Ryan. So EUS offers real-time Doppler imaging. So it enables really precise targeting of the perforating vessels or the collateral vessels which require treatment. It's particularly useful in actively bleeding gastric varices when the endoscopic visualization is really difficult. So for EUS, you really do not need a visualization as far as the actively bleeding varix. You would be able to see them on endosonography, and you could use the Doppler to also to assess if you have adequately treated these varices. Once the Doppler signal is obliterated, we know for a fact that these varices have been treated. So that way, it allows precise targeting, and I think that's how it's really revolutionized treatment.
Yeah, and certainly with EUS, it allows you to use glue or coil embolization. It also allows you to identify, perhaps in certain cases, is there a larger perforating vessel that can be targeted, which would be an advantage over direct endoscopic intervention. One potential downside, as you both know and have outlined within this paper, is with direct endoscopic intervention, you need to have a target. You need to have a very obvious target to put the needle in, whereas with EUS, you may have a little bit a better view, or at least a different view for what may lie slightly deeper. Guru, I'll stay with you for a minute here. What would you to endoscopists in the field who are looking to add these therapies to their practice? Is there any advice or suggestion, or anything that you would give to them to provide some insight about how to go about this in a safe but yet effective and appropriate manner?
Yeah, this EUS guided angiotherapy requires a lot of training. It not just for the practicing clinicians, it also requires training for the entire endoscopy unit, right from the way the room is set up, the accessories you require. But overall, it's useful to have the cyanoacrylate glue and lipidol in your endoscopy suite. It's also useful to have a knowledge on the different coils available. We use the platinum nickel alloy coil. They vary in size from 12 millimeter to 20 millimeter in diameter. It's important for the endosonographer to kind of choose the right kind of coils. Typically, we choose the coils based on the size of the varix, and the pre-deployment diameter should be like 1.2 to 1.6, the size of the varix. The idea is to pack the varix with multiple coils And these coils act as a scaffold, and then you could use the glue. And we typically, at our unit, we use fluoroscopy as well, and we mix the glue with lipidol. That is readily visualized on fluoroscopy. And it also slows the embolization risk, reduces the embolization risk. So once the coils are deployed, we would try to inject glue along with lipidol, and then we'll confirm with Doppler whether the Doppler signal is obliterated, and then we move on to the next varix. Overall, we use like the 19 gauge needle or the 22 gauge needle, and as I said, we target the perforating vessels. Sometimes the perforating vessels can be identified. Very often it cannot be. In which case, we target the intramural, the largest vessel possible, which we think is most likely to be. And these fundal gastric varix, the EUS, the tip of the scope sometimes could be retroflex. So sometimes in that situation, we would want to use a transesophageal pleural approach because we would be able to see the gastric fundal varices from the transesophageal approach, and that would give us a more straighter pathway for the needle. And also we tend to lubricate the scope with oil, pine oil. And it's important to realize that, the glue can sometimes, and, we use each varix, we use just a single needle. And for the next varix or the next target, we would change the needle. It's important to recognize that the glue can clog the needle and make it unusable. So we may need to use different needles. And it's also important to, use the pine oil to keep cleansing the scope. Otherwise, the glue could destroy your scope.
Yeah, those are certainly important things. I've always thought that with EUS guided angiotherapy, as much as the procedures are technically challenging, yet beneficial, there's so much preparation before the case, as well as important factors after the case about when to remove the needle, or do you leave the needle in and take the whole scope out? Some people have cut the handle off using metal snips. So there's a lot to consider with that. Erik, with the endoscopic approach, it really isn't different, right? I mean, drawing up the glue can be a bit of a thing on its own, and then same with getting rid of the needle. Anything you would add to what Guru said regarding kind of preparation or important factors for those who wish to add this to their kind of armamentarium? I think we might have lost Erik there for a minute, but I suspect he'll come back. What I was getting at is that, at least the glue that we have access to comes in like a 1 cc or I think it's only 1 cc aliquots that you basically need to crack the vial and kind of suction out the glue and then reload it into a syringe. And oftentimes to get an adequate amount of glue, particularly for a patient who has a large varix sac, can be time consuming. So it's important that everybody knows what they're getting into before going forward with this. Guru, while I have you still here, what do you see as kind of the highlights or the main key points that you want our readership to take away from this document? Like, what do you think is the biggest benefit to the ASGE readership with this?
So, when we reviewed the literature, Ryan, I'm sure you knew that, the glue coil embolization, there have been a few randomized studies, but most of them are multi-centered retrospective studies, but still some high quality data out there. And they have studied under various circumstances, acute active bleeding, or for secondary prophylaxis after the active bleeding has happened, or for even primary prophylaxis. There is a single study which was recently published. But overall, the message I have is EUS guided glue and coil embolization together works better than EUS guided coil alone or EUS guided glue alone. This is what was the overarching message I was able to get after reviewing several studies which have looked at this. And the risk of glue embolization is far less if glue and coil are combined together. The risk of rebleeding is far less when US guided glue and coil are combined together. And more recently, glue and coil combination has been looked at for primary prophylaxis of gastric varices as well. And that's an interesting topic, and probably that's where we are heading as well.
Thanks, Guru. And I would say, you know, as Erik mentioned, you know, these two kind of similar but separate procedures with direct endoscopic intervention and EUS guided intervention are very complementary. And I think that the EUS approach gives us a little bit of a different dimension in cases that may not be so straightforward. So with that, I would like to thank you guys for the document that you've put together. I think it's an outstanding document. Certainly will be welcomed by the readership, and you know, we appreciate the time and effort put in to construct this document, because these do take quite a bit of time. So with that, we'll close the podcast. Thanks to Erik Rahimi, Guru Trikudanathan, and certainly our liaison, Lauren Wilhoit. Thank you again.
Thank you, Ryan. Thank you, Lauren.
Thank you, Ryan.